Okay, so Ninan Varughese, is that if I pronounced your name correctly? Okay, good.
Varughese.
Ninan is the Director AI of the UNAIDS New York office. He has been with UNAIDS for over 17 years and has previously worked with the World Health Organization in Geneva, Switzerland. Ninan has been involved with the response to AIDS from the late 1980s. He has over 33 years of experience at the country, regional, and global level. Of these, more than 28 have been in the field of health and development, including HIV/AIDS, malaria, tuberculosis, sexual and reproductive health, and social marketing. Before moving to the development sector, Ninan worked for many years in the advertising industry. The UNAIDS office in New York works at the political level to help unite the world in responding to HIV and AIDS, accelerating progress around the Sustainable Development Goals, and to ending AIDS as a global public health threat by 2030. Over the last 6 years, Ninan has been an active proponent on drug policy and its impact on the HIV epidemic. So thank you so much for joining us today, Ninan.
Thank you so much, David, for that kind introduction. And also, just want to put on record our thanks to DRC Net Foundation and you for organizing this during this very hectic HLPF virtual meetings. But thank you all for joining as well, and thanks to Charles for his introductory discussions. I just want to give as David mentioned, an overview of the HIV situation globally. As you know, the International AIDS Conference is ongoing in San Francisco and Oakland, and UNAIDS just launched its global report on the 6th of July, called Seizing the Moment, Tackling Entrenched Inequalities to End Epidemics. And it was launched by our Executive Director, USG, Vinny Banyina, as you know. The report talks about some key issues. It says that the AIDS pandemic remains a global crisis fueled by inequalities. There have been great successes in HIV response, but progress is extremely uneven. Because of persistent inequalities, we will miss the 2020 targets. We must double down and act with greater urgency to reach millions still left behind. We also see that gender inequality is denying women and girls the ability to make their own healthcare choices. And then, of course, COVID-19 has seriously impacted the AIDS response. Even before COVID-19, we were not on track to meet the global targets for 2020. Now that COVID-19 crisis is blowing us way off course, but community resilience and innovation has shown the way in mitigating the impact of COVID on HIV. As you know, the 2016 high-level meeting and the political declaration contains programmatic, epidemiological, and financial targets for 2020. 2020 has come, but we are missing a lot of these targets on all financing, programmatic, and epidemiological impact. 3.5 million additional new HIV infections because of not reaching the fast track targets. 820,000 additional AIDS-related deaths because of that. Women and girls continue to suffer and be at the forefront of the epidemic. And unequal gender power dynamics, harmful gender norms, and masculinities and violence against women and girls continue. Despite impressive gains in access to treatment, AIDS still remains a leading cause of death among women 15 years and older. Adolescent girls, young women account for 1 in 4 infections. About 4,500 adolescent girls and young women between age 15 and 24 become infected with HIV every week, and that's unacceptable. Moving on to COVID. As countries grapple with growing COVID-19 pandemic, the leadership, resources, and infrastructure of HIV responses are being mobilized to meet the challenges. So we are leveraging HIV leadership and lessons against this new pandemic. National directors of AIDS programs and coordinators are leading COVID-19 responses in about a dozen countries. The Global Fund and World Bank have made funding available. The IAS is also doing special webinars. Local, national, and regional international HIV community organizations are bringing their energy and experience to the COVID-19 response. As the coronavirus spreads in countries in sub-Saharan Africa with high HIV prevalence, there is evidence that people living with HIV and people with active tuberculosis are both at higher risk of COVID-related morbidity and mortality. People living with HIV and people at great higher risk of HIV infection are also facing life-threatening disruptions to health and HIV services as COVID-19 cases overwhelm health system capabilities and capacities and lockdown limit movement and strain economies. Voluntary medical male circumcision, condom production and distribution, PrEP, HIV testing and treatment, and other programs have all been negatively affected. Efforts, we've seen that COVID-19 is amplifying inequalities. Efforts aimed at controlling COVID-19 have penalized the most vulnerable in society, such as women, the homeless, those living in poverty, or those who are already marginalized, stigmatized. There's been increase in domestic violence, vulnerabilities related to children being out of school, COVID-19 restrictions and police powers used to harass, harm, and arrest sex workers, LGBTI, and other marginalized and criminalized groups. Uses of criminal law to sanction COVID-19 exposure and transmission of COVID-19 are a reminder of the stigma and discrimination that people living with HIV have been facing for decades. We have seen that if services to prevent mother-to-child HIV transmission and was similarly halted for 6 months, there would be increases in new children's infections and mothers across many countries of the world. I just want to come back and touch some issues related to specifically to drug policy. More than 12% of the estimated 2 million people who inject drugs globally were living with HIV. And of course, the latest UNAIDS estimate suggests that people who inject drugs in 2019 had a risk of acquiring HIV that was 29 times higher, greater than a person who did not inject. One of the really worrying finds that we have in our new report is that a majority, 62% of new adult infections globally in 2019 were among key populations and their sexual partners. These populations include workers, people who inject drugs, that's about 10%, prisoners, transgender people, and gay men and other men who have sex with men, constitute small proportions of the general population, but they are at an elevated risk of acquiring HIV infection, in part due to discrimination and social exclusion. Also, there are significant gaps in HIV testing among key populations at high risk of HIV infection, meaning that 1/3 did not know their HIV status. This testing gap is even higher and larger for people who inject drugs. Drug use or consumption, as you know, and possession of drugs for personal use is specified as a criminal offense in 111 of the 134 countries with available data, with only 17 countries reporting that possession of a certain amount of drug is allowed by law. This meeting that you have convened is very timely because a repressive enforcement of drug laws, including harsh criminal penalties and the registration of convicted drug users, force people who use drugs away from public health service into a hidden environment, increasing their risk-taking behavior and heightening the chance of acquiring or transmitting HIV. Women who use drugs continue to face major challenges in accessing sexual and reproductive health services, and the human rights-based, public health-focused and gender-responsive HIV prevention and care that they urgently need. Rates of intimate partner violence and gender-based violence among women who inject drugs are up to 5 times higher than they are among women who do not use drugs. Discriminatory laws, policies, and practices, and multiple intersecting forms of violence, stigma, and discrimination, including those related to accessing health, education, employment, and social and legal protection services, or when interacting with law enforcement, are among the barriers that have a significant negative impact on their access to healthcare. And as I mentioned before, there have been alarming reports of use of police force and powers to harass, harm, and arrest vulnerable and criminalized groups such as sex workers, people who use drugs, and people living with HIV and LGBTI people. I just want to end by saying that as international discussions and commitments to accelerate research and development of COVID-19 vaccines got underway, UNAIDS has co-initiated the mobilization of a movement for a people's vaccine with a group of over 150 world leaders and experts led by South African President Cyril Ramaphosa and backed by civil society, academic experts, thought leaders, and philanthropic organizations, united in an open letter calling on all governments and other actors to ensure that any quality assured vaccines, treatments, and tests for COVID-19 be free of exclusive rights, produced at sufficient scale, distributed equitably, and made available to all people in all countries free of charge. And I just want to throw in a plug here, David, if you agree. Tomorrow at the HLPF discussions at 10:30, our executive director will be addressing issues on inequality and leaving no one behind at the HLPF main thematic section. I want to end there. Thank you, David.
What's the best website for to go to for that?
So all our reports are available on the unaids.org website. All the data that I mentioned is available. There are slides available that you can use. Everything is on our website. So please go ahead and have a look there, please. Thank you.
I mean, is that a 10:30 session tomorrow with your executive director being broadcast publicly?
Yes, it's being webcast.
Okay. webtv.un.org?
That is correct.